Everyone again. So what we decided to do this year was to split the discussion according to the three major subtypes of breast cancer and go through what is available currently and also what is being researched in terms of the best way to manage this disease. So let me see. So these are my disclosures. And for this first part of my talk, before I go into the details of the first subtype, I wanted to give you just some general notions regarding metastatic or advanced breast cancer. For some of you, this may be, you know this already very well, but because I suspected already that would be people who are here for the first time or not very familiar, I thought it wouldn't hurt to go through this initial overview about metastatic disease or advanced disease. So let's first clarify what is metastatic disease and why we sometimes call metastatic and other times we call advanced. So what you see here is a very simplified way to put the stages of breast cancer. So on the left, you have what we call early stage, and this goes from stage 1, where the lymph nodes under the armpit and the axilla are negative, to stage 2 or 3. Some part of the stage 3 can be called locally advanced. These are larger tumors that have lymph nodes involved. And then on the right side, you have what we call stage 4, which is when the tumor spreads to other organs besides the breast and the axilla. We also call that metastatic or advanced breast cancer. So the idea of providing treatment after the diagnosis of an early breast cancer is to try to avoid the relapse, particularly the relapse at the distant site. And this we do with what we call adjuvant or neoadjuvant when it's given before surgery treatment. And this can be chemotherapy, endocrine therapy, or biological therapy. And you see that the higher the stage, the higher the risk of developing metastasis. And one other, I'd say, big difference between early stage and advanced stage is that early stage is potentially curable, and advanced stage for the moment is incurable but treatable. At diagnosis, the majority of cases are early breast cancer, at least in what we call developed countries. But there is still some 10 to 15%, sometimes a little bit more, cases of stage 4 at diagnosis. And in areas of the world where there is no screening, where there is less awareness about the symptoms, cancers are diagnosed later. And so it can go up to 50 or 60% of stage 4 at diagnosis. So why does a cancer becomes metastatic or advanced? So what you can see in this cartoon, the green cells are the cancer cells. So they start to develop in the breast. And at a certain moment, they gain certain characteristics that allows them not only to grow, to proliferate, to multiply much more than a normal cell. That's one of the characteristics of a cancer cell, but also they gain capacity of invasion. They are able to invade the tissues around them, including the blood vessels and the lymphatic vessels. And that's why they go into circulation. If they go into a lymphatic vessel, they are sometimes picked up by the lymph nodes, but they can go directly into the blood vessel and they are not picked up by the lymph nodes. So this is how they enter the circulation, and they go to another organ We don't know yet why they pick up an organ or another, why some go to the liver or another go to the lung, but they go there and start to grow in those organs, giving smaller tumors. And these smaller tumors is what we call metastasis. Okay. So just to clarify now why sometimes we use the word advanced instead of metastatic. So we decided to use the word advanced breast cancer to include two situations, the metastatic, which I already described to you, but also one that is a locally advanced inoperable. And I put some images there. I don't want to scare anyone, but this is sometimes a situation that we see. And this is, of course, more often where there is no screening, but it may occur in rapidly progressive tumors. And if we have this situation of very locally advanced disease, but not yet in the distant sites, these patients are also lost. They are not early, they are not yet metastatic, and so they are sometimes lost. So we decided to include them in this definition of advanced. So we have two situations in advanced breast cancer. Now, the other point I wanted to discuss with you before going to the details are the goals of treatment in the metastatic setting. So I already told you that this is, in the vast majority of cases, an incurable disease, but treatable. And what we want is to achieve a balance between efficacy and toxicity. We want to give a treatment that is efficacious, hopefully that would improve survival, which is the most important part. So survival is the duration of life. Also that delays progression, has a durable response, and at the same time can control symptoms and improve or maintain the quality of life. So to do that, it cannot be too toxic. Otherwise, the toxicity of the drug will not allow the quality of life to be improved. And we think, or many of us believe, that the first step towards a possible cure in the future would be to be able to transform metastatic disease into a chronic disease. So meaning a disease that you can live several decades with a good quality of life, even if you have to take some treatment. So just this balance between quality and quantity of life. Now, how do we decide what treatment to give? So I think you all have heard about precision medicine, individualized treatment, treatment tailoring. So the treatment tailoring is important in every stage. It's important for early disease, but it's also very important for metastatic disease. And how do we do this? How do we individualize the treatment? So we have to look at the patient and also look at the disease. Obviously, when we look at the disease, we have to understand the biology. What type of breast cancer are we talking about? Is there any biomarker, any specific target in that cancer that we can use to choose the treatment? And you see there in green, and I will explain a little bit better, what are the biomarkers that are very useful for us to decide the treatment. But then there are other characteristics. For example, if it is a relapse, not a what we call a de novo, not a diagnosed stage 4 immediately, but someone who has had early disease, we have to know what treatments were given for early disease, how well or how bad they were tolerated, and what was the time, the interval between that treatment, so the diagnosis of early disease and metastatic disease. And also, we need to know if it is a very, what we call tumor burden. So if there is a lot of tumor, a lot of metastases, or just a few metastases. And then there's a lot of other characteristics of the patient. And you see that I put there biological age and not just age, because age is not just a number, you know. Some of you are older than others, but it doesn't mean that your bodies have the same age as your identity card. And some people are younger but are more fragile than other people. They can be 70 and very fit. And so age by itself should not make us be more aggressive or less aggressive in the type of treatment, but we should take into account what we call performance status and comorbidities. That means other diseases that you may or may not have when you have the disease. And then there are some other factors that are important, socioeconomic, psychological factors, available treatments. You will be discussing this later on. Availability is, of course, something very important, and always patient preferences, because everywhere the patient preferences is important. But if you are treating a disease that it's not curable and you need this balance between quantity and quality of life, this is a very personal balance. And so we have to discuss and decide for each patient individually. So you may summarize all these factors in patient preferences, patient characteristics, disease clinical characteristics, and tumor characteristics regarding biology and biomarkers. So I know I have to go a little bit fast, but my slides will be given to you, and then you can read them at your leisure. And if you have any question that I cannot address, I'm happy that you contact me and I'll try to address your questions later. So the two main problems in oncology is what we can say, patient selection and tumor resistance. So what does it mean, patient selection? So is to choose, I should have put, it's not exactly patient selection because we're not selecting the patient, we're selecting the treatment for the patient. But what I mean here is this match, that we find the correct treatment, the correct dose, the correct time and moment to administer a treatment for that specific patient. And we and for that we need to identify the target and to develop targeted therapies. Now, I said I would go a little bit more in detail regarding the biomarkers, and I don't have the time to go into all the details, but the message that I want, or some messages that I want to pass regarding biomarkers, is the following. The quality of care and the quality of treatment starts with the quality of pathology. So everything we do, medical oncology, so we prescribe the treatment, depends on the pathology report, on the analysis of the tumor. So if that analysis is not of good quality, we may be giving the wrong treatment, and the wrong treatment may not be efficacious and may still be toxic, right? So one of the most important things for all of us to advocate around the world is high quality pathology. The other message is that it makes no sense to ask for a biomarker or to spend resources on a biomarker if you don't have access to the drug that targets that biomarker, right? So we should only ask the biomarker if we know what to do with that result. And that's why we still do not recommend for routine practice to do those multi-gene panel. So to go and do, foundation one type of analysis of the tumor, because in breast cancer, we still don't know what to do with those results. We only need a couple of biomarkers. So maybe it's worthwhile to do what we could call a breast cancer specific panel, right? And what would that panel have? So it would have those biomarkers that are there in red, because those are important for treatment decision. And they are the hormonal receptors, particularly estrogen receptor, the HER2 receptor. It is important also to know if it's an hereditary cancer, mostly related to BRCA genes. There is another mutation that it's PIK3CA mutation that has a specific target. And another alteration, this one in immunohistochemistry, that is PD-L1, important for immunotherapy. And maybe maybe next year or 2 years, I will be putting here another one that it's called the mutation of the estrogen receptor because of a new class of agents that is coming that I will explain in the last part of my talk. So the other point I wanted to explain to you, because it will help you understand the natural history of metastatic disease. And this is, I have to tell you that it's one of the most common questions from any patient, and possibly also the most difficult, the difficult characteristic of this disease for the patients to understand and assimilate, if you understand what I'm saying. So let's start with the left. You see there a tumor, and you see that the tumor is composed of different types of cells, right? It's because there is what we call heterogeneity. So the tumor is composed of different cells. They are not all the same. And that's why some may respond very well to a treatment and others may respond less well and better to another type of treatment. So when we give a treatment, then in principle, there will be a response, and you see that the tumor becomes smaller. It doesn't disappear, but it does become smaller. And what happens is that with time, the tumor becomes resistant. So I usually say that tumor cells are very intelligent, and they not only know how to hide from our immune system, but they also find a way to escape the treatment that we are giving. And so this is what we call resistance. And so the tumor regrows, even if you're still receiving the treatment. And then it becomes bigger, and you see that it becomes even more heterogeneous, more complex, with more mutations. So this is what we call disease progression. So what can we do at this time? Well, we have to stop the treatment that we were giving and start a new treatment. And then in principle, there will be a response, and this is a cycle. And that's why we sometimes say that life with metastatic disease is a kind of a roller coaster, because, you know, there is good happening when there is a good response to the treatment, but then eventually there's always resistance. And then you get depressed because you say, why did it stop working? It was working so well. And then you go down, emotionally down, but then there is another option, and it will lead to a response again. So that tells us a couple of things, but it tells us that it is very important to biopsy the metastases. Today, I will not talk about that, but I can answer questions if you have. But it is important because the biology will be different according to the evolution, and the treatments that we give will induce differences in the tumor. And it's also very important to have access to multiple lines or multiple types of treatment, because we need to change treatment during the course of the disease. So how can we overcome this resistance? We have to try to outsmart the cancer. And I know that some of you don't like this war analogy, but in terms of treatment, it helps a lot to explain. So I apologize for those who don't like the war analogy, but allow me to use this just to explain the types of treatment. So we have the first treatment that is very well known as chemotherapy, that we usually compare to a bomb because it kills the enemy, but also the good cells around. And this is because the target of chemotherapy is the tumor, the cell that is dividing. And I'll come back to this later on. And then we have the targeted agents, those who are like missiles that go to the cells that have those targets. And the two most important targets in breast cancer are the hormonal receptors and then a receptor that it's called HER2. So this defines the two very important subtypes of breast cancer. One that is sometimes called hormonal dependent or estrogen receptor positive, that depends on the stimulus given by hormones. That is the one in the middle, and the one in the right that it's called HER2 positive disease. And then when you don't have any of these receptors, we call it triple negative, that I will speak in the second part of my talk. So let's start now into the details of each of these subtypes. So we'll start with the HER2 positive that I already explained to you, is the type that has a lot of those receptors called HER2. So how does this work? And what type of treatments are the most important treatments here? So you see in this cartoon, and I will move it and you will understand how it, when it moves, how it works, that the receptor, the HER2 receptor, is a part inside the cell and a part outside the cell. And what happens is that when there are what we call, let's call it growth factors, stimulus, what we call their ligand, when they connect to the receptor binds to another one, and they both go inside the cell. And when they go inside the cell, they tell the cell to grow and also not to die, because normally our normal cells, they are born, they grow, they have a function, and then they die. It's a natural evolution of our cells. But tumor cells don't die. They have this capacity to be immortal. And that's why they continue to grow and accumulate and give all these problems. And also they tell the cell to migrate, like I showed you in the beginning, to go into the blood vessels and go somewhere else in the body. So the best treatment that we have for this subtype of breast cancer is something that blocks this receptor. And the first one that was developed was a drug called Trastuzumab. The commercial name is Herceptin. Some of you still know it by the commercial name, but now there are many biosimilars, so it's always better to say the chemical name and not the commercial name. So Trastuzumab blocks the receptor, and it will stop everything that is below the receptor. So many years ago, I was still young at this time, so the Trastuzumab trial it's called one of the landmark trial, because the HER2 positive breast cancer was one of the most aggressive subtypes. Cells grow very fast, the cells that have this receptor. And all we used to give was chemotherapy. But in this trial, we showed that instead of giving just chemotherapy, if we would give chemotherapy and this antibody, the Trastuzumab, you can see that the curves separate very nicely, both for progression as well as for survival. So the addition of Trastuzumab led to a longer survival, a longer time without progression, and a higher response rate. So this has changed completely the natural history of this subtype. So the main messages of treatment for this subtype of breast cancer is that anti-HER2 therapy has to be offered as quickly as possible. So immediately at the beginning of the diagnosis of metastasis. In fact, now it is already used in the early setting, but it still should be used in the metastatic setting. And something that we consider a paradigm change in oncology is that we continue to use anti-HER2 therapy even after progression. So usually in oncology, if we give a treatment and there is resistance to that treatment, we don't give it anymore. But what we have proven for this subtype is that it is indispensable to continue to block this receptor, because if you stop blocking the receptor, the progression is much faster. The tumor grows much faster. So we need to block it. Now, during the years, we've been developing other treatments. We have another antibody that it's called Trastuzumab. And what you see here is that they both link to the portion of the receptor that is outside the cell, but in different spots. And so they can be given together and they will block the receptor in 2 spots instead of just 1. And this we have shown that it's more powerful. And here is also the result of another landmark trial, the Cleopatra trial, where they compare chemotherapy and Trastuzumab versus chemotherapy, Trastuzumab, and Pertuzumab. And you see again that the curves separate, and that the curves separate for progression, time without progression, but also survival. And what I wanted to show you in particular is the median survival of patients treated with this combination is more than 5 years. So 57 months is more than 5 years. Okay, and this was a big advance in metastatic disease treatment, because usually patients would not live more than 2-3 years. But here you can see that they live more than 5 years when given this type of treatment. So this has changed the guidelines, and you will see that throughout my talks, you have also the guidelines and the recommendations. So the recommendation is that we should use this Trastuzumab, Pertuzumab combination with chemotherapy as our preferred or standard first-line treatment, both for those who have received Trastuzumab in the adjuvant setting and for those who have not received. Now, another type of anti-HER2 agent. So, and this was the first antibody drug conjugate. Very complex name, but what does it mean? It means that you have an antibody. In this case, it is the Trastuzumab that you see there in green. And the antibody functions as a bus, and it transports the chemotherapy. So the DM1 is a chemotherapy agent that you see those stars, 3 stars connected to the antibody. That is chemotherapy that is transported by the antibody until the cancer cell. And what happens is that it goes inside the cancer cell and it frees the chemotherapy inside the cancer cell. So by doing that, it is more efficacious because it goes to the cell that has this HER2 receptor, and is also less toxic because it affects less the normal cells. It still affects, but affects less. So this is the way that all the antibody drug conjugates work. And this will help you understand other drugs as well. But this was the first one, and it's also an efficacious drug for this subtype of breast cancer. Now, more recently, we have this other antibody drug conjugates, and you can see here on your left the same image, so you understand. There is the antibody, and then all these, I don't know, yellow dots that you see here are chemotherapy molecules. There are many more chemotherapy molecules than in the TDM1 that I showed you. So this is one of the differences between Trastuzumab DERUXTECAN or T-DXd and TDM1, is that T-DXd has more chemotherapy associated to the antibody. It also has a different type of chemotherapy. And I will, in my other talk, I will explain what is this bystander effect, not to complicate things too much here. But I think you understood, and I hope you have understood now, what does it mean, this word of antibody drug conjugate. So the antibody here functions more as a transporter to bring the chemotherapy to the cancer cell. So this is a busy slide, but it's just to show you that everybody is very excited about this new agent, this Trastuzumab deruxtecan or T-DXd, because in the first results that we had, this was given to patients that had received a lot of treatments before. Medium number of treatments given before was 6. And you can see in the right upper part of the slide that there was a lot of patients that had a response. The tumor shrinked with this drug. And I explained to you that the tumor becomes more and more complex and with more mutations and more difficult to treat with more and more treatments. And so when a drug is very active after many other treatments, we always get very excited about it because it means that it's an active drug. However, we saw that it may also have some substantial side effects, including a lung disease that can be fatal, that we call pneumonitis. And this pneumonitis, or let's call it inflammation of the lungs, can be fatal. So it's, again, this balance between efficacy and toxicity. So later, after this first study, this drug was compared with the other antibody drug conjugate that I explained to you, the T-DM1. So this was a head-to-head comparison, T-DXd versus T-DM1. And what they saw here, again, you see the curves separating. So meaning that DERUXTECAN was superior to T-DM1 when given after that other combination that I showed you, Trastuzumab, Pertuzumab. So that has led to the recommendation that DERUXTECAN, where available, because it is not available everywhere, can become a preferred second-line treatment after Trastuzumab, Pertuzumab. But we have to pay attention to this possibility of toxicity to the lungs. Now, if we don't use it in second line, we can also use it in later lines. And importantly, for those countries or patients who don't have access to this treatment, T-DM1 remains our preferred option as second line, okay? Now, finally, for this subtype, you see here the mechanism of action of some other types of drugs that we call small molecules or TKIs, tyrosine kinase inhibitor. And you see that these molecules, what they do is that they bind to the part of the receptor that is inside the cell, okay? And there are 3 of them, tucatinib, neratinib, and lapatinib. The most important one is tucatinib, and I will explain to you why. So it's also possible to combine these drugs that block the inner part of the receptor with the monoclonal antibodies that block the extra part of the receptor. See, this is okay. So this is another summary slide to tell you something about tucatinib. So tucatinib was studied in combination with the trastuzumab. So blocking the receptor outside and inside the cell, and together with a chemotherapy that is called capecitabine. And why was this so important? Well, for one, it continued to show an improved survival, even in patients who had received various or multiple lines of treatment before. But also, it is able to cross to our brain and to treat also brain metastases. And brain is a very difficult place to treat because the brain has something that we call the blood-brain barrier. And this barrier was created to protect us. So when we have an infection or when we have some toxin, they don't cross to the brain. The brain is protected. But that acts against ourselves when we want to give a treatment, because if that treatment is unable to cross that barrier, it will not treat the brain metastasis. And tucatinib is able to cross that barrier and to treat brain metastasis. And that's why it's such an important treatment that we currently have. So now we consider also a treatment option. So in summary, for this subtype of breast cancer, these anti-HER2 treatments, they were able to transform this subtype that was one of the most aggressive in a subtype that has the best long-term outcome, the best survival. So you see that it is the gray curve. It used to be close to the blue curve, and now it is close to the black curve. So the black curve is the ER-positive disease, and the blue curve, the one that does worse, is the triple-negative breast cancer that I will speak afterwards. There are many new drugs coming into this part, many, especially antibody against other receptors in the cancer cell, as well as other antibody drug conjugates, so transporting other drugs. But the main take-home messages for this subtype is that the biggest benefit and the most cost-effective agent is trastuzumab, and that we need to be able to keep blocking the pathway until we have available options. So I summarize like this so that if you have to advocate in your country, you know what you should ask. So what we consider must have is trastuzumab or any biosimilar, but the trastuzumab is crucial to have. And something else that is crucial in some of your countries is not available is to be able to use trastuzumab after progression. This is a big fight because in many countries, this is not possible to do. And so what is very important to have is pertuzumab, something that I call good to have, because it would be very important to have different options, is T-DM1, T-DXd, and tucatinib. There are drugs that I did not mention for the sake of time, but we do not recommend neratinib or margetuximab, and lapatinib is inferior to trastuzumab. But in countries where you cannot continue trastuzumab, then it's important to have lapatinib to have different options. So that is the end of the first part of my talk.